So I want to thank everybody for joining us today. My name is Christie Yee, and I'm the Practice Management and Implementation Specialist for Euclid Systems Corporation. I just want to give you a little background on myself. I have a little over 20 years of specialty contact lens experience. I served as a director for the Minnesota Contact Lens Society, and prior to joining Euclid, I was a contact lens specialist for Park Nicollet, which is a large OD-MD practice here in Minnesota. I'm incredibly proud to be a part of Euclid's team. For over 25 years, Euclid's been a global leader in orthokeratology and myopia management. Today, our lenses are on millions of eyes around the world. And integrating Euclid orthokeratology into your practice is very easy. We have an empirical three-factor fitting process. All we need is your RX, your Ks, and your HVID, and our algorithm is going to take care of the rest. So that means you don't need a fit set, but you're going to be able to achieve an 87% first fit success rate. Our proven design is offered in Euclid Max. This is a material that has a DK of 180 and is the highest of any overnight ortho K brand in the United States. So not only, in my opinion, do we have some of the most easy to fit ortho K lenses, our lenses are also some of the healthiest. So I want you to know that when choosing to partner with Euclid, you have an entire team behind you. We don't just give you awesome lenses. We really want you to help be successful. So we have an entire clinical and scientific affairs department that's available to answer any technical questions that you may have and provide you with white papers and research. And we have a sales team with decades of experience and tons of resources to help you get started and be successful. And I really want to make certain I give a shout out to our amazing consultation department. Our department is open from 8:30 in the morning to 8 p.m. Eastern Standard Time, and we have 7 lens specialists that are here to help you with any of your lens needs. So whether that's troubleshooting a difficult case, you just need some advice, best practices, fitting tips and pearls, even if you need your hand held through your first fitting, they've got you. We also recognize that getting started can be very difficult. There are a lot of things to consider. You're going to need tools and resources, and there's the little matter of getting your entire staff on the same page. And that's really where I come in. We offer one-on-one consultations to our current customers. I speak to many doctors who are just interested in getting started and have no idea how to do it. So this is really where we'll work together to define some of your goals and help you through the process of getting set up for myopia management at your practice. Once you're comfortable and set up, I do offer staff training, and I feel like this is really important because everybody at your clinic needs to understand and speak to the health benefits of myopia management. And this is one of the reasons why I'm so excited to be here with you tonight. This is going to be the first part of a 3-part series implementing myopia management into your practice. Tonight, we're going to start at the beginning. We'll discuss some of the importances of defining your vision and goals for myopia management, and then we're going to also cover some of the concepts of pricing strategy, along with common pitfalls, best practices, and then we're going to finish the evening with office policy, forms, things like wearing contracts and informed consent. We're going to save some time at the end to answer any questions, so please feel free to enter them into the comments as we go. To help me, I'm super excited to be joined by the one and only Dr. David Kading. Dr. Kading is one of the most influential optometrists and innovators in eye care. He is known for his expertise on topics such as myopia management, dry eye, irregular corneas, specialty contacts, and anterior segment disease. He's lectured all over the world, he's published hundreds of articles, and he hosts 2 podcasts. And if you haven't subscribed, I highly suggest that you check them out. They're available to listen on Apple Podcasts and Spotify, and we'll be sure to post those links at the end of the webinar. So thank you, Dr. Kading, for being here and being a part of my implementation series. This is an incredible honor for me. I'm so excited to have you here tonight.
I am so excited to be here with you, Christy. This is going to be a lot of fun talking about some really, really important things, especially when people are really starting to get going in their myopia management practices.
Yeah. So to get started, when I first meet with doctors that are getting started in that implementation process, I like to ask them questions about their overall goals and motivations. I feel like this can be really insightful for me because it helps me provide the best resources that are specific to their goals. But I also feel like it's really important for doctors to really sit down and define what they're hoping to achieve. And, just by setting some tangible goals and assigning some time frames, science says you're statistically more likely to be successful. So, with that, in the beginning, when you were setting up your practice, how important was it for you to establish those goals and, really define a mission statement?
Yeah. Well, we know the statistics around goal setting and actually writing down your goals. It's a pretty substantial difference between writing it down and having it happen and not writing it down and hoping that it happens. So that, I think, is a really key component, but getting a person to the why is also the big component. And if you're listening or watching tonight, we know that you already have an interest in doing that. And I think it kind of all starts with that. And in our practice, our mission is to enrich people's lives so they can succeed to their greatest potential. And our vision is dramatically impact the lives of myopic children, specialty contact lens dry eye, and binocular vision patients. So those are the North Stars that we always shoot for. And so if you take that into the exam room, that means if you hit a myopic child and they come into your office and are sitting there, you have to do something for them. And that's really where I think is the big crutch is when we said myopia is a disease, we have to do something for them. It then substantially altered the perspective of we have to go at this. I think the goal setting around that really sets up is forcing yourself to say, I'm going to be accountable to that mission, and here's how I'm going to be accountable. Looking back over, you can do that in your electronic record system and see how many myopic children did I see over a certain time period, a quarter or a year, and then saying, I'm going to gauge my success based upon how well I do in that area. And for us, we're targeting 100%. We certainly don't get there, but we're probably in the 80s or 90s, of if a myopic child comes in, we implement myopia management. And sometimes that myopia management implementation isn't yet orthokeratology, soft multifocals, or atropine for the patient, but it's getting the seed planted and moving them. So starting those substantial numbers of setting that target, and not just a percentage, but actually setting the number that you need to do. We have a number target that we try to hit, and our external marketing helps to drive that number as well as our internal marketing. But we've set a specific number. And I know we're going to talk about the team and getting them on board, but we involve them and we get them involved from a perspective of, certain amount of bonus money and things that go to that so that everybody's on board with that. But having a number that is written down, and for us, it's on a spreadsheet, and we track against it every single month that we go through the year to try to hit that. It's really important to get that number written down.
Yeah. So do you find that when you go back to like your initial goals that you set up for like the very start of your practice, are they still driving your progress forward today, or have you made changes along the way?
Well, from years ago, yeah, we certainly are targeting that. And each year we set a percentage growth over the prior year. And, what we're realizing is that it's not a linear line, that we're not, targeting 25 patients the first year and, that it's a straight line. It tends to be that it starts off as a fairly small slope, but then it starts to pivot and go up because you're getting you're getting those patients returning,
Yep.
plus you're getting all of them talking about the services that you're doing to their friends, and if every patient brings in 2 patients, you're going to see a substantial increase in your practice. So we're targeting substantial growth, not just a 5% or a 10%, but we usually are doing a 25 to a 50% growth over the prior year with our myopia numbers.
That's amazing. And so I know you mentioned that you're communicating your goals to your team. How do they help drive your overall success?
Yeah. Well, we could probably have 10 or 15 different podcasts or webinars about this very topic. But, years ago, we implemented something called the Great Game of Business. And in our practice, we share all of the numbers of our practice with our team, from the costs, the costs of the practice, the revenue that is coming in, the sales reports, and so forth. And so with that, our team is able to see how, number one, we're helping these patients improve their lives. But number two is, how does the office operate underneath the revenue that is generated from these types of services? And then they can see via a bonus structure that we set up that when we do more of certain things, myopia management is a big one, that they can get to a bonus a little bit faster. And so they actually help to set some of the targets that we have, and then they're motivated to try to bring that about. And we try to talk with each person in the office. You know, the front desk person might say, well, I don't impact that number at all. Or the technician is like, I only see the patients who come in. How am I the one marketing? An optician's like, I'm selling glasses. I'm not impacting myopia management. But if everybody gets talked to about how do you impact that number, then they can take ownership over all the areas of the practice and see how they can impact the growth of it.
Nice. And do you feel like that transparency has led to better overall team results?
Absolutely. Not only from a numbers and a revenue standpoint, but the transparency where everybody has to be active in, and everybody in the office has specific numbers that they report on every week that we meet. And by doing that, it brings about a level of engagement, which is a lot better. So that the level of engagement of being involved forces everybody to be included in that. And it has brought about, certainly transparency, but also it has brought about a drive for them to see where they impacted and how they can make it better.
Right. When we look at your patient base overall, when you start thinking about the myopia management practice within your clinic, do you feel that your myopia management patients are like more loyal to your practice because of the care they're receiving?
I think that they are, they see that we're doing something different, right? Obviously, we're seeing that child who was referred in maybe from another provider, or one of their friends is doing myopia management, and the parent brings them in. The parent sees that we're maybe doing something a little more, advanced than the other provider that they were. So they end up coming to see us as the whole family. And it really grows the practice that way. But certainly from a loyalty standpoint, where else are they going to go to get the measurements that we're doing that is looking at something that maybe they weren't getting somewhere else? We've incorporated axial length into our myopia practice. I have a whole idea about whether you have to do that or not. I think it's a good idea to work towards implementing axial length, but if you don't, you can still manage it. But by having that particular instrument in our practice, it's helped it's helped our patients see that we're tracking things a little bit different than they've been tracked somewhere else with another doctor's office.
Yeah. So, there's obviously some, like business financial impacts that have occurred because of myopia management.
Yeah.
We also have, just the extended loyalty with our patients. Besides that, like what really drives your passion for myopia management? Because you've been kind of on the myopia management scene, I think, kind of since the beginning. So what is your driving motivator?
Well, I spoke to our mission statement of enriching people's lives so they can succeed to their greatest potential. And, seeing that that was something we could do to slow down people's prescriptions so that it wasn't as high is certainly something that drove us initially in the early days. But I think over the years, as I've learned more about myopia and its impact on people, long term, it really has started to open my eyes of why we have to do myopia management. I think of a couple of patients, for example. I have this guy whose name is Steve, and I've seen him for a real long time, and he's a -9 myope, right? And I saw him in his 40s and his 50s. And now he's got all of the issues going on with glaucoma and macular issues. And he's got, he ended up having cataract surgery, which really impacted him because now he can see very well.
Right.
But yet he has all of those medical conditions that we look at as high risk. And I look across the board at the patients who are walking in with pathology. And, many of the ones that come in that have pathology have had a high prescription. And it just makes me think, well, is there anything we could have done to stop this from happening? And yes, we could have slowed down their myopia when they were little. It wasn't an option for us back then. We didn't know as much as we know now. But now we can really target that. And now we can really go at it and help those patients not become the Steve that I have in my clinic.
Yeah. Yeah. For me, it's personal too. My husband's family is Asian, and a lot of them have had retinal detachments. And I think we automatically kind of assume that like some of these eye issues that happen with high myopia are something that happens in advanced age. but I've
Right.
got a cousin who is 35 years old that has had a retinal detachment. And,
Oh,
those,
wow.
those things are kind of life changing, clinically, we consider him a success because he's able to achieve 20/30 vision in the one eye, but he has a significant visual field deficit, and he's about 2 diopters aniso. So, being
Mm.
35, pseudophakic with a 2 diopter difference, working on the computer is quite a challenge. So,
Wow. Yeah.
these are life changing, for future patients.
Yeah, not just the people that are, 60, 70, 80, 90 years old, right? We're seeing
Yeah,
it younger and younger, and it's
younger.
certainly happening.
Yeah.
Mm-hmm.
So let's go ahead and pivot to some like pricing strategies for myopia
Mm.
management. I seem to see two common structures, kind of like a fee for service model, but then I also see more commonly the global fee model. And now at
Mm-hmm.
my clinic, I'm a scleral lens fitter, so we just kind of went straight to that global fee. It's kind of what we were used to. It
Yep.
just seemed kind of natural to go that way. And honestly, during a lot of the consultations that I have with practices that are already doing myopia management, this is probably the most common one that we see in office. And honestly, when we were just doing like the ortho K for myopia management, this worked actually reasonably well. But about 6 years ago, we decided to go ahead and add natural to use soft multifocal lenses, and we did a global fee for that as well and set it at a lower cost. Now that's an entirely different conversation, but we learned really quickly that the pricing became a decision maker for modalities when it came to parents. And so instead of choosing a lens based on the merits and benefits of the treatment that lens could provide, cost was dictating choices, which is something that I really wasn't crazy about, but it's ultimately something that we stuck with for a couple of years. Now, this is a little bit of like a longer story, but I probably feel like it's worth sharing because if you stick with myopia management fitting long enough, you're going to have these one-off situations that pop up.
Yeah.
And, I've watched like a lot of implementation webinars and a lot of troubleshooting webinars. And I got to tell you, the what ifs were never covered. So the first time that this happened to me, it was kind of an eye-opening and educational experience. And, just to kind of give you an idea here, I had a 10-year-old child who was approximately 2 months into an ortho K fit, and he developed some complications. His vision was great. He was 2015. The fit looked great.
Mm-hmm.
Cornea was perfect. He was a happy kid. And then at about that 2 month mark, his mom called and he's like, or she's like, my child is complaining of some light sensitivity. So we brought him back in the afternoon, took a look at everything. Everything looked great. And, honestly, when I got the slit lamp over his cornea, he wasn't like shielding away from it or anything. So I'm just like, well, let's try a lubricant. Let's see what happens. I
Yep.
follow back up with him in a week, and she's like, no, he's squinting. He's having some light sensitivity. So then I'm thinking, like, shoot, does this little guy have some like edema that he's waking up with that's just resolving before I got a chance to see him?
Yeah.
So, we brought him back, and sure enough, there was some small edema. So, we tried a
Mm.
couple lens adjustments, and we just couldn't get it to resolve. And ultimately we made the decision to transition him to a soft multi, and, he was doing really well with the soft multi. Everybody seemed happy. And then mom comes to me and she's like, well, do I get a refund? And I was like, for what? But then she reminded me that there was a price difference between the ortho K and the soft lenses, and she'd like the difference back. So here I am on the spot. Am I obligated to give her money back? Probably not. Did I just invest more time to refit her child into a different lens? Sure did. Did I give her the $500 difference? Yep, I did. And I also realized I never wanted to be in this situation ever again.
Mm-hmm.
So the learning experience for us was that we wanted to make certain we had the ability to pivot, because
Yep.
we didn't want to ever have an awkward financial conversation ever again. And this works in reverse too, because you can have children that develop corneal astigmatism and soft multifocal lenses. And so you can get them set up, and then at the 6 month or year mark, yep, 3/4 of a diopter of astigmatism. And now I'm going to need another $700 to refit your kid, or, whatever that looks like.
Right.
And so what we ended up doing is creating a global fee for myopia management versus like a specific modality. And that was really a game changer for us. Basically, what we did is we set up a myopia management plan with the parents. We, just basically said, we're going to watch your child closely. Every 6 months, we're going to check the progress and reevaluate. And if we need to make changes, we will. And it just adopting that model made things so much simpler. And it was just so much easier. And I really feel like when doctors are like sitting down and just planning their structure, you just really need to be prepared for these one-off things, these changing modalities. Eventually, you're going to have a child that just cannot do it, for whatever reason, and you need to cancel a fitting that you've maybe started, or you're going to have some warranty issues. So, taking all that in, have you experienced situations like this in the past? Like what is your approach to kind of a pricing structure?
Yeah, yeah, it is something that has to be thought through and discussed. And, I think it goes back to when you take your child in to get braces, you're not buying braces, you're buying straight teeth. And whatever the doctor has to do, the dentist has to do to get the teeth straight is what you're paying for. And I think when we oftentimes in the eye care world think about the services that we provide, we think about the product that we're using to provide the service and may base our pricing off of the number of visits that it may take or the cost of goods that things come out to. And so that's where we kind of place our value. And really, the straight teeth is the value for that dental model, and the slowing of the myopia is the result that we're shooting for. So I think to your point, we need to be selling myopia management, not the product or the service to get there. It's an obligation upon you as the eye care provider to select the one that's going to work best and is going to fit best for the patient. And ultimately, I think it should be on you to pay the difference if you selected one that didn't work, or maybe there was a little bit of an obligation if you used a global. Now, that was where if you use a a la carte model and method and you charge per visit the patient can come in, then regardless of what ends up happening, if the patient wants to switch from one to another, then they pay for it. Like you, I prefer the global fee that we have, and it encourages the patients to still come into the office, and it encourages them to move forward with coming in for 6-month visits and so forth. We also bundle the product in with the services, that this is the package for the entirety of the thing. We don't break out the cost of the ortho K or the soft multifocals that's included is in the global.
Mm-hmm.
And we also switched over probably about 8 years ago or so to myopia management as a fee. And it didn't really matter which solution we went to as far as soft multifocals or orthokeratology. And if a patient ends up doing atropine in addition to, which many of our patients do, we bundle that in the price of it as well. They have to buy it elsewhere. But that's a direction we're, trying to go more and more of, is getting atropine into the same cost as the other things. And right now we have it as a little bit less. But yeah, I agree with you. It's something that we don't think of very often. And if you are going to switch your patients or need to switch your patients, it's important that the patients are willing to do so and aren't driven by the cost, right? I don't want my patients selecting the glaucoma medication purely because it's just cheaper, which sometimes they have to, right? Their budget doesn't afford them the option of going to a better drug or a better option. And in our case, we try to keep our costs as low as we can, as much as we can, because we want to encourage people to do myopia management. But we set our prices so that whether they choose one or the other, if they have a preference, this is the same cost. It doesn't influence their decision because of the dollar amounts. And that's really what I want them to be able to make that decision wisely. I can go with the counsel that I recommend them to. Most often they choose which I recommend to them. And that global kind of set structure tends to work. I agree with you.
Yeah. So now, like when we look at orthokeratology specifically, I've had a lot of doctors that I'm consulting with ask like, okay, so when do you discontinue orthokeratology? And to be quite honest, I have never had a child say, okay, I want to be done now. Everybody that I fit in orthokeratology for the most part has wanted to continue their orthokeratology after the myopia management treatment is done. So how do you guys transition your patients from a myopia management patient to a adult orthokeratology patient?
Yeah. So, doing orthokeratology in our office is less expensive than doing myopia management. And if you again look at what are you doing, we're giving them good vision versus slowing the progression of myopia. And so the selling of the item that we're selling is good vision versus myopia management, and that carries a little bit less of a cost. And so doing that, we make that transition. There is a price difference that they pay. Now, there is going to be some kiddos say that they head off to college and they're only going to come back once a year, and we may shift them over to orthokeratology or something else as opposed to just doing myopia management. So there will be a cost difference. But many times when I'm speaking with the family, we talk about whether we're doing this for myopia management or we're doing it for vision correction. And if we're doing it for myopia management purposes, we want to see them for the follow-ups. We want to check to see. We want to make sure that we're dotting those I's and crossing those T's. The cost difference is a little bit. It's not a huge difference. It's not like $1,000 difference. And so, making that decision to go stay with myopia management, if there's going to be additional visits included, then they tend to slide into that. But you're right. Many of the kids who have been doing orthokeratology for myopia management, they tend to want to stay in it as they head into college. And we talk with the parent about the benefit of that. And when do you stop, right? That's the real question, that there is no right answer. We do see that there is adult myopia progression and has been shown to slow down the progression with the use of orthokeratology for adults. There's several studies that have been published that talk about that. And, me personally, I increased in my myopia in undergrad and grad school. So I talk with the family that it may be good for us to just check to see if there's still stability while they're in college. And then we can decide at any point to stop doing myopia management and decide to go a direction. If that's ortho-K, great. If it's going into soft daily disposables, great. There are options that we can consider. But that's a decision that we make individually with each patient and their parents.
Right. And so now with your college age students that are maybe off at school, are you still trying to get them back at the 6 month mark, or are you going more annually with these adults?
Yeah, the beauty about setting Christmas to be about 6 months away from the summertime works really well because usually
Yep.
they're coming back for Christmas. They may be leaving for school and we see them in August or September, and then it's only a 3 or a 4 month. So it really kind of depends. But yeah, we still encourage them to come back and we can check things at that time period if they're back around. And there's plenty of other vacations that they may be home for, and we can see them for those visits at those times too.
Right. So like the last topic I really want to cover with you is going to be forms and office policy. And I feel like this is probably one of the areas that optometrists struggle the most with. This is the one that actually holds things up, I think. They know they need to have something, but they're not really sure what to put in them. And I've seen they're all over the place. I've seen some as long as like 12 pages and others that are barely like a couple paragraphs. So, with that, Dr. Kading, you've been doing this a long time. What do you think are like the things that practices just have to have in order to get started?
Yeah, Christy, I told you that we've got a mission and a vision, and then we also have a core values in our practice. And our core values are that what we call our gifts. Those are the gifts that we offer to each other as a team, how we try to act towards our patients. And the gifts stands for generosity, initiative, faithfulness, teamwork, and simplicity. And simplicity is something we're always wanting to shoot for. Like, how can we make this process of an eye exam as simple as possible? You're darn right. A lot of times we make policies based off of the 1% of patients who complain about something, right?
Sure. Yep.
And so often we answer the what if questions in the paperwork, and it goes from 2 pages to 15 pages real quick because we want to just get all of those answers, all of those potential things answered. So I've tried to take along a an aspect of generosity when it comes to like, what if? Well, how would I want to be treated, right? What
Sure.
if a lens is broken? What if a lens is lost? What if all of those sort of things kind of come into play? And so we've tried to reduce our pages that we give to a page or 2 pages. And the other thing that we oftentimes think about is, if something could be 3 individual pages, it's probably better to keep it 3 individual pages as opposed to one document that is 3 to 4 to 5. So we actually have one of the forms that we have, and we can talk about this, is a warranty form, right? Our patients had enough questions of like, well, what if I break my scleral lens? What if I break my ortho K lens? What if I break these sort of things? So over the years, we developed a warranty program, and basically the warranty cost was what my cost for a pair of lenses is. And then if a patient comes in and they break their lenses 3 or 4 or 5 times, I'll still give it to them because somebody else is paying for the warranty, right? That's how a warranty works, is you make your money off of the people who don't need to
Right.
use it.
Yep.
So that's one of the things that we did. And we actually just changed some things in our practice so that everybody gets a warranty. So if you break your lens, no problem. It's just included, and we added a little bit extra to our cost. Many people probably may need to be looking at their costs right now, right? Inflation is what it is. It's gone
Yep.
way up. And so our cost of everything is a little bit more. So we've had to increase our costs in our practices. And this was a good time to look at our policies of, can we add things into the overall cost so that if something happens, we feel better about it. So you're right. And I think the shorter, the better. Oftentimes people want to share the risk factors and have them written down. And one of the things that we say to our patients is, if your eyes get red, your vision is blurry, those are 2 things that we want you to come in immediately for an office visit and see us right away. So we put some of those risk factors in there. We don't list every single one, just like you don't list every single one for every soft contact lens that you see, but we
Right.
list some common ones that are frequently asked about. And that really becomes a frequently asked questions of how to deal with these different issues.
So now I want to go back to the lens warranty. So
Yeah.
you're offering it to everybody. What do you think your actual utilization is for lens
Well,
warranty?
how often do we actually order a new set of lenses or a new pair of lenses or something? Is that what
Yep.
you mean?
Hmm.
Yeah,
Yes.
I would say it's less than 30%.
Yeah.
Yeah.
So
And you know what? When it happens, it's absolutely, let's get you taken care of, right? No
yep.
problem. We'll solve that. It used to be that it was like, well, you need to bring in your broken lens so we know that you're not lying to us, right? And
Yeah.
that just doesn't show the patient that you trust them, right? It doesn't build trust, and it doesn't show that you appreciate who they are. So now it's just like, yeah, no problem. We'll take care of it. And if I get taken advantage of, it doesn't happen that often. But what if I do? Oh, well, right?
Right. It's such a low
Um,
percentage.
It's a low percentage, and we just want to be right all the time, right? But I want to be generous, which speaks to the first
Yep.
of the G in the gifts, is I want to be generous. And if somebody needs to take advantage of me to feel better as a human being, that's okay. I'm not going to let them walk all over me, but we'll let this slide this one time.
Sure. So now going back to your pricing structure, do you feel like the simplicity in your pricing structure in having kind of a fee for myopia management that is in kind of like inclusive of the soft and the orthokeratology lenses aids in keeping things more simplistic in your forms and setting your office policies as well?
Yeah, I do. You know, we aren't the cheapest in town, um, but we're really good about myopia management. Other people are good maybe with ortho K or soft lens fitting, soft multifocal fitting, but we're good with ortho K and we're good with myopia management. And so our fee reflects that, right? Our
Sure.
fee
Yep.
reflects the fact that we're doing more than other people are doing. And, we'll just take care of whatever needs to happen, right? To your point is what happens if you have to refit a patient midway through?
Yeah.
Doesn't happen very often. But we charge you for myopia management, we'll take that on, right?
Yeah.
Maybe twice, three times a year, we have those added costs that come into it. And I don't want the patient to have to really suffer as a result of that. Maybe they're paying a little bit more than they would somewhere else, but when things happen, we got you, right? I just had a patient the other day break a lens and she felt horrible. She was like, oh no, what am I going to have to pay? No problem. We'll get you taken care of. We'll get a lens ordered for you tomorrow and we'll get it here as quick as we can. And that's what I would want somebody to do for me, right?
Right. Yep. So how do you guys handle cancellations? Like let's say you've got a child that, during the consultation process, everything looked great. Um, Everybody was on board with the plan. And then as it turns out, he or she cannot touch their eyes. They don't want you to touch their eyes. They don't want their mom and dad to touch their eyes. Like mentally, they're just not ready for this type of a situation. I'll share that, we struggled with this policy in our office because we knew that there was going to be quite a bit of chair time initially doing like all of the scans and the consultation process and ordering the lenses. And then, usually this particular problem is found during like the INR stage of things. So we're already a couple of visits in. And so we really struggled with, do we offer a full refund and just, we'll try again later, or, do we want to have some type of financial commitment? And so like ultimately we decided that there was going to be some shared interest there. And so while we did provide a refund, it wasn't 100%, just to make certain that, they were as committed to the process as they could possibly be. But how are you guys doing something in your office?
Yeah, we do something similar and, sharing with our patient that all we have is time. And so it doesn't happen very often. And I think, Christy, you and I would probably agree this happens less than 10% of the
It's
time.
really
So
rare.
I don't want to make an entire policy around it, but that is one thing that we've done. And I'll share more about this, but we now have a subscription model, which is how most of our patients pay, is they pay every single month. But whether it's a global fee, we had this, or whether it's a subscription, there is a cost to start. And that cost to start is non-refundable. And that makes sure that the patient and the parent and that I am committed to this. And we move on from that. And if the patient ends up stopping or they just don't want to do it, and the parent is like, hey, this isn't for us. We don't like contact lenses, or I want my child to become myopic, or whatever it is they decide that they want to stop, then there is that small fee that we keep, and then we refund the rest, hoping that maybe we can get them back next year. Maybe the kid will be ready to go, and then we move on from there. But there is just that little bit to help cover some of those initial costs, like you had, like you said, and it doesn't need to be a lot. It just needs
Yeah.
to sting a little bit so
Yep.
that they don't just quit.
Yep. So motivation.
Yeah.
All right. So you had mentioned that you've moved to a subscription model. How are you liking the subscription model over a global fee? Are there pros and cons to each model that you've found so far?
There obviously is. So there's several financial benefits of both. One, you get your money right away on a global fee. In a subscription model, it allows the patient to not have to pay as much right up front. The other thing that I really like about it is we see myopia management's a huge part of our practice, right? Hundreds of thousands of dollars come in from myopia management. And we see these big waves in our business when myopia management is really big one month and then low the next month and big the next month. And so from a cash flow perspective, going to a subscription model where everybody is paying every single month, you're going to see some that more people come in one month than another, and we get a re-up, or we get new patients, and then our costs will go up a little bit, but then they stay up, unless you have a ton of people stopping the process. So that is an advantage. The other thing along with that is, in a subscription model, the patients are able to do as much or as little as they want. So if they don't come in at a 6-month visit, that's okay. You paid for it, but you didn't use it. If they don't come in every 3 months for an axial length measurement, which is included, that's okay. It's there to give us more data. It's, however it may be. One of the advantages is, if you do a global fee, you collect that money when the patient comes in. So I'm going to collect from them today, and then 12, 13, 14, 15 months later, I'm going to collect it again. And it's kind of dependent on when the patient comes in. In the subscription model, it goes until they return their lenses. So they can stop the subscription, will stop the credit card processing when they give me their lenses back. And so if they go 11 months and they want to re-up, great. I'll buy new lenses for you at that time. If they go 13 or 14 months and then they return for their lenses, I've still been able to generate that revenue for those other months. But I think what the biggest thing is, and we've already seen this happen, is there have been some people who just didn't want to do a care credit or anything like that, and they wanted to get on board, and they weren't getting on board because of the upfront cost.
Sure.
But they were able to come in, we were able to reduce that overall price per month for them, and they love it. It's worked really well. On my podcast, Andrew Nurcook from Chicago was the one who brought this up to me, and has done a really, really good job helping to educate many of us about its benefit.
Right. So overall, it sounds like you're getting higher patient acceptance doing a subscription-based model, just again, because it's more affordable upfront. It spreads it out over a longer period of time.
Yeah, and we haven't been doing it for a full year, but that seems to be the case. Yes.
Excellent. I think you're the first doctor I've heard that's implemented this. So I'm really excited to see how this goes for you.
Yeah.
I'm very intrigued. So I have one last section I wanted to cover, and that's lens, like wearing instructions and lens care instructions. Are you giving those written to your patients, or do you provide verbal instructions?
Yeah, so I think a real good way to do that is to include, a video that you have that you can share with the patient, because the mom and dad, they're like, how are we supposed to do that if they don't wear lenses? And they can get home and they can watch a video of how it was done. One thing that we're looking to do, and I'm going to have to give credit to Philip Cheng in Australia on this, that he does, and we want to implement this now, is he actually has hired some of his longtime myopia management patients that are 15, 16, 17 years of age, and they maybe come in once or twice a week, and they do all the trainings for the kids that are coming in, and they're doing it after school, and the kids most often come in after school. And so it's not us training them, but the ortho K wearers who've been doing it for a long time, and they're excited about it, right?
Yeah.
So having that excitement around it, and oftentimes when our staff is doing it, right, they're doing it in the middle of dozens of other things. It's really, cumbersome. So we don't give care instructions of how to put lenses in on paper. I know that some people do. What I think is the best thing for you to do is to have a video that you have recorded that you can post on a YouTube page and then send your patients to it. And that's really, really helpful. My daughter just started doing orthokeratology because she crept into the low myope space. She's a -1/4 and -75, and we're doing ortho K for her. And, I've never gone through that. What happens when you get home? Now, I'm very comfortable putting lenses in, obviously, but I'm teaching her how to do it. And we're doing that at home. And I just made me think, like, what are the things that we need to be doing for parents that are better? And I think the biggest takeaway from my daughter becoming an ortho K patient is to be okay with it failing once in a while, right? My daughter, she's, hammered at the end of the day. She's just so sleepy. And, she struggles with one lens and then the other one just won't go in. And it's brand new for her and it's just uncomfortable. I can get it in, but she's like, so we just take it out, we put it in the case, and we'll say we'll try again tomorrow, right? In the first couple of days of doing it, I think that's a good thing to do. And congratulating your child that you're doing well. You've heard this so many times in the exam room with patients, I know you have, is when the mom or dad raises their voice, like,
Yeah.
just open your lid, right? It's like, that isn't gonna help, right?
No.
So a lot of peace and a lot of forgiveness and a lot of acceptance of what's happening through the process. And in going through that with the patient, having a video so that they can watch, I think bringing in another ortho-K patient to be the one training them, which we're about ready to start doing, and having a method that is very acceptable to come in as many times as you want. If somebody's really struggling, I think most of us know about the importance of the eye drop test and sending them home with an eye drop. Getting comfortable actually touching your eye is another big one. And those things of having just acceptance and like, it's all going to work out, right?
Yeah.
We're in a marathon with myopia management. It's not a sprint.
Right. So with the lens care, I've been getting this question a lot, and it's a complicated question to answer. There is a lot of supply chain shortages going on right now with our rigid gas permeable contact lens solutions. Clear Care is not currently offered in care kits. Boston has really pulled back on their office supplied care kits. There's still a few other brands that are available, but they're not available in stores, so the patients have to special order them. What is your practice doing, and kind of, what is your thought process on some of this?
Yeah. Well, when a child is first starting to wear lenses, unless there is an allergy that we know of ahead of time, I think it's a good idea to put them in a multi-purpose solution. I'm still able to get those solutions right now in the office, so I haven't hit that of like other people are hitting. But if we do get to a point where we can't order care kits for the office, guess what we're going to do? We're going to go buy them at the store, right? If we can't get them at the store, our patients can't get them, and we shouldn't be offering that solution, right? So we'll go buy them because the cost of a bottle of solution is less than $10. And, giving that away to a patient isn't a big cost when you're looking at a new patient wear, right?
Right.
What else can I give you? That's what I want to know, is what else can I give you to make this valuable? And giving them a bottle of solution that you had to buy for $10 is okay. So that's how we go. As we move into wearing lenses longer, we may move them over to Clear Care. But in that initial first patient dispense, I like them to have something that they can rinse the lenses if they dropped and so forth. So my go-to initially is a multi-purpose solution.
Okay. All right. Well, I think that's all the time we have for tonight, but I really want to thank you for joining us. And again, if you guys have any questions, Dr. Kading and I are going to stay on to answer those. And we appreciate you joining us. Hi.
Hello.
You look fantastic.
Thank you. My beard's a little longer than when we recorded that.
My hair's a little straighter too.
I know, it looks great. I was about to compliment you.
We've pulled the most amazing costume wardrobe change in seconds. So we have a lot of amazing questions, and for everybody who's still listening, if you have them, please don't be shy. Go ahead and add them in there. We're going to get to as many of these as we can. And I'm just going to just jump right in and start asking them for you. So after treating the patient for the first year, when is the next follow-up recommended?
Yeah. So for myopia management, we're managing their myopia and we want to know what's all happening. If somebody has slowed down the progression and their axial length is relatively flatlined or nearly flatlined, I may let them go 6 months or maybe even a year if it's a little bit of an older kid. But most people, I want to see about every 3 months for an axial length measurement. And that 3-month axial length and 9 months axial length in my office is with a tech only. And then we get the data and then we can look at the graph and talk with our patient about it. Um, our device that we use is the Myopia Master, and it gives us an auto refraction as well. So it kind of tells me a little bit about the patient, even if I don't see them. And then I like to see them every 6 months, and we kind of do an eye exam and then a 6 month myopia check and then an eye exam and so that's how we do it, whether it's the first or the 15th year. I don't think I've done 15 years on anybody, but whether it's the first five or sixth or seventh year, we tend to do it pretty much the same. And as they get older and they've stabilized and everything seems to be in pretty good shape, they probably don't need to come in every 3, maybe even 6 months. But that's on them to decide how much they want to see.
Yeah, and I'll just share that that's pretty much my practice as well. We're pretty much for like the aggressive like progressors, so the ones that we were seeing alarming progression with, I'll have them come back every 3 months, and then once we kind of get that stabilized, I've traditionally gone to every 6 as well.
Cool.
So we have a patient who's in his first week of fitting, and we see that his vision is improving day by day, but the lens is displaced inferiorly. What should we do? So for this one, I'm going to chime in for my consultation team. This is a great question for consultation. And I know Abby would love for me to share that in that first week, you probably don't want to be making any rush decisions on making lens adjustments because that cornea is still changing. Now, after like the second or third week, if you're still seeing some inferior displacement, that lens might be too sleep and you might need to flatten some of those alignment curves. But this is a really great situation for consultation to get involved. Anything you'd add?
Yes. However, we're starting to see some data that says that an increase in aberrations, whether it be spherical aberration or coma, may have some positive effect in slowing the progression of myopia further.
Yes, I've heard that too.
Yeah, so this is data that's out there. And, other parts of the world where they do myopia management, it doesn't look like a bullseye very often, right? It does in some cases, but I've heard from other people who's looked at topographies and is like, that it's just crazy, but it's working. Yeah. So it could be that induced spherical aberration or coma may be benefiting the patient. And I bring this up to say that having done hundreds and hundreds of these patients, there were many, many of them that would come in with 20/20 or 20/25 vision. Everything was perfect to them, except the fit didn't look right to me. And so I would then go through 5 or 6 or 7 different lenses and, 15 visits trying to fix this fit because it wasn't good. Meanwhile, it may have been that the fit was okay for myopia management, and we were helping to slow the progression even better as long as it's healthy and you're not doing damage, which a little bit of displacement isn't going to cause a health problem. So I would just say that maybe in the first week, you're going to continue to monitor it, but don't jump to making tons of changes with a little bit of that fit's not perfect.
Yeah. And I guess that was one of my big learning curves when I first started with all of the specialty lenses, was not to chase that textbook picture that you look at, you're like, oh, this isn't perfect. I should change something to make it look perfect. If the vision is great and you're seeing a reduction in the myopic progression, you're just adding more chair time and reducing, any profit margins that you've had by chasing that perfect picture on your topography.
Yes.
So the next question we have is, if you use a global fee, which I do, have you ever had a case of a patient wanting excessive office visits more than clinically necessary? And if so, how do you recommend handling that?
Yeah, no, there certainly are times where a patient may desire to come in more often than they really may need to. And some of that may be that your global fee is really high and it, you may just need to see that patient 2 or 3 times a year and everything's going well. So it's that assurance that they're there. And then, every once in a while you could say, hey, our global fee covers all of these things that need to be seen. If your desire is to come in and check on some things, we certainly could do that under a contact lens follow-up appointment or a patient requested myopia consult. And so in those cases, you're letting them know that you would be happy to see them, but that may be outside of the global fee, and just letting them know I'd be happy to see you, but that would just fall outside of the myopia agreement that we have. If there is a problem, you can come in and see me, but there is no problem. And so if you just want to check, happy to check, but it would be outside of that, and there'd be an additional fee.
Yeah. The other thing too is maybe consider utilizing staff. If it's a situation where it could be a tech check versus something that like a doctor needs to be involved in, utilize your staff if it's just like a quick, like I just need some reassurance or something like that on something that's a little more rudimentary and simple.
Mm-hmm. And with our subscription model, which we spoke about, I'd see them in a second. If
Yeah.
they just want to come in all the time, let's hang out.
We have a patient who wants to stop using ortho-K lenses because they want to have LASIK surgery. How long should they stop using the lenses before an evaluation for LASIK?
Yeah, no, the answer is not solid there. I can't give you and tell you exactly what's going to be the case. And in many cases, we have used this philosophy as 1 month for each decade of wear. So, presuming that this is a 20, 30-year-old, the likelihood of that being more than a month is probably not all that high. But that's what I would do is I would have the patient go out of ortho-K, let their lenses go to a stability where their cornea isn't changing. And then I would check that every month. And once you saw stability for about 3 or 4 months in a row, then I would say that it would be okay. You could probably push it and do it sooner than that, but I probably wouldn't.
Yeah, and I would say coming from Park where we have we do LASIK at Park, and so I have a lot of GP patients that were in this situation. That adage of 1 month per decade of lens wear was exactly what they were looking for. But your LASIK surgeons, sometimes they do have different opinions, and they're going to let your patient know if they want it longer. Are either of you ortho-K candidates, and have you fit yourselves? So yes, I wear the Euclid orthokeratology lenses. I just started about 6 months ago. I'm 41 years old, so I'm just starting that adventure of presbyopia. I have myself slightly undercorrected, doing a little bit of monovision. For me, it's working great. I love it. I have some oblique astigmatism that's kind of annoying with trying to do like a multifocal contact lens. So for me, it was really just like deal with the glasses or just on and off business. And so the orthokeratology has been a great addition to my life.
That's awesome. I also wear orthokeratology lenses. I'm 43, and although it's not quite clear right here, it's fine right here. Prior to wearing orthokeratology lenses, I actually had a prism diopter of vertical, and I had that in my spectacles, and then I would wear, regular contact lenses, and then would wear glasses or something for reading or computer glasses. And that was a relatively normal thing for me on my long computer days. And I actually don't do that anymore with orthokeratology. And I don't know how it fixed my vertical, but I don't get headaches or eye strain anymore. We have it just fit right. And, you can modify with your optic zone or your treatment zone to get a little bit of an added effect. And so, yeah, I wear them, and I tell my patients all the time that I wear them. My past resident wore orthokeratology. My current resident is a hyperope, so that doesn't work for her. But a high hyperope. We could do low hyperopia, but a high hyperope. So yeah, if you're a myope and you are a practitioner, I would get a hold of Euclid and see if you could get a set of lenses and get yourself set up. It'll really help you with talking with your patients.
Yeah, I really agree. And just with like any lens that I was fitting, I pretty much was my own first fit of any lens that I was going to start fitting. So, that was putting scleral lenses in my eyes, that was putting hybrid lenses in my eyes. I wanted to be able to know what that experience was like prior to trying to describe that to a patient.
I also mentioned that I wear my lenses probably 4 or 5 nights a week. And so I don't wear them every single night. And like we had an all-day meeting today. We didn't see patients, and I didn't wear my lenses last night because I knew I wasn't going to do a lot of computer. And I mean, I'm fine.
Yeah, same. I try to wear them pretty regularly, but there's nights where I just get lazy and they don't make it in my eyes. But as long as I'm in that 4 to 5 nights a week, I'm maintaining my correction.
Yeah, cool.
So the next question is, if you refit an Ortho-K lens because of a problem, do you wash them out? And if so, for how long?
I suppose that pause was because you're wanting me to answer. Yes and no, we wash them out. It kind of depends on the problem. But if it is a major problem, then yeah, we're going to wash them out. Usually that happens within the first year, and usually it happens within the first couple of months or even the first month, and then we're going to make some modifications. And there are patients who come in a year or 2 or 3 later that need a major modification, in which case we then share with them, hey, in order to maximize the improvement here, we are going to need to refit you and have you take a vacation from your Ortho-K lenses. And then I also share with them that that's valuable information, so we can see where their refraction is, see how much of a prescription change they really went to. Usually by this time, they've been putting in contact lenses out in and out of their eyes anyway as a child. And so soft lenses can be used during that process, where maybe not at the beginning, maybe not as easily. And so it's usually not a major ordeal unless it's a super high myope and it's going to take maybe 3 or 4 weeks for them to wash out.
Yeah. And I will say this is a really great a spot to really recommend annual replacement with the lenses. These lenses do change shape. They do warp. Just with use, you start picking up like little fine scratches and things like that. And so I've had some kids that have gone missing for 3 or 4 years, and they come back, and all of a
from your office. Oh,
yes,
phew.
yeah. And so
missing.
I've only had them. We just adopted, and I've only had them for like 2 weeks. I hope not. But no, so I've had some kids that go missing for a few years, and then they come back, and the vision is not where it's supposed to be, and then you're questioning, is the lens changed, or is it a true actual prescription change? And so in some of those situations, it's easier to just have them take a lens vacation for a couple of weeks and then redo topography than trying to order a new lens off of a potentially warped cornea.
And for that reason, if you do a global fee, your global fee needs to include a time period. And they need to come back for annual adjustments. And if they go beyond that time period, then they may need to be charged the higher global fee, the new patient rate.
Yeah.
For us, it was about 16 months. If we hadn't seen you for 16 months, we were going to charge you the higher global fee. If they've gone on away. If they're in a subscription model, that's kind of on them. We just keep getting paid the whole time that they're gone. Yeah. And so that motivates them to come back and get a new set of lenses, which I agree with you. It's how long does a lens last? I don't want to find out. I want to replace a lens before it's worn out and before it damages the eye.
Yeah. So the next question is, how often do you see a myopia management patient once the actual fitting is done? 3 months, 4 months, 6 months, and then do you do anything different the second year?
Yeah, I think we kind of hit on that with the first question. It's about every 3 months. Now, if it had, if our fitting process took us 3 months, then I'll just hit the 6 months and the 9 months, because I got axial lengths every time they came in during that initial visit, but then it's just every 3 months.
Yeah. And then in regards to your subscription-based service, one of the doctors would like to know, is the cost to start a certain percentage of your global fee?
Christie, I'm not sure I understood that question.
So we had discussed that there was a cost to get started with myopia management at your practice.
Yeah.
And I think, if, for example, a patient canceled or decided to step away, was that a certain percentage of your global fee? And if you're willing to share the percentage.
Yeah. So we would say to a patient that if they want to stop the process at any point within the first, I think it was 60 or 90 days when we were global, that we would give them 50% back.
And that's exactly what we're doing at my practice as well.
Mhm.
And then one of the doctors would like to know, how do you manage your subscription model? There's no context to this, but the very next question is, do you use software programs to collect payments? And, you know, I think people are really intrigued by the actual subscription model and would like to know a little bit more about the ins and outs of the like administrative part of that.
Yeah. So there is not a universal great program that all of us that are doing subscription models are using. Most everybody that I've spoken to says that they've talked to their bank to figure out a process for it. And so what we do is we have a credit card processing system that can do a recurring charge on a monthly, weekly, however often basis, that it'll just continue to do it. Now, that's actually not our primary credit card vendor. It's actually a different vendor than we use for everybody else, but we just use it for that. Different banks have systems that are built into it. So you may just want to go and visit a couple of banks in your area and say, hey, I want to start charging people on a monthly basis for something. Is there something that you have built into your credit card processing that could do that? So I think that's the answer to the question. And right now we don't have anything incredible that I've seen from a software standpoint. Nor does Andrew Nurcook, who is the one who brought it into me. He worked with a local bank as well in how to do that.
And then the next question is, why did you choose to go to the monthly subscription fee over offering something like Care Credit or similar financing?
Yeah. So there's a couple of reasons. One of them was because I wanted, and we kind of shared this earlier.
We did.
I wanted some stability to my to my revenue. And you know, if back when I was doing 1 or 2 or 5 myopia a month, you know, a shift of $5,000 or $10,000 or 15 or whatever it was, 1 month to another wasn't a substantial. But now when I have 5 patients 1 month and 30 patients the next month, and then I have 15 and then 7, and it can kind of fluctuate, you know, depending on the year, schools going back to school and so forth. So when you're getting into 2, 3, 4, 500 patients, your cash flow can be substantially altered. And some people are okay with that. And I think I could weather that storm. That's not a big storm to weather as a business. But if I can gain the same amount of money over a divided period of time, and the first year is the worst year because you're getting everybody signed up and you didn't get that full amount. But if you can get into the second year, then it all works out. The second reason for this is why every subscription model is a benefit is I can give more things to patients. These people are now attached to me in more ways than just a once a year. And they can come in on a regular basis and they know I'm going to take care of them. And if they don't come back, then it costs them, right? If a 12-month global fee patient doesn't come back, you don't generate that revenue at 13, 14, 15, 16 months. You generate the revenue when they come back and you had a huge gap. I don't have that with the subscription model. It's on the patient and it will increase the compliance, which will make that everything better.
Yeah, I 100% agree. I think the subscription model is actually genius. So again, with the subscription model, if they stop their monthly payment for any reason and don't return your lenses, like now what? Have you had any issues where patients have just kind of like gone AWOL?
No, we haven't yet. And if that does happen once in a while, it probably is not a big deal because again, I like to deal with the 98% rather than the 1-2%. But that's kind of the agreement that we had up front is I just had them sign a piece of paper and said, we'll be happy to stop your credit card payment, which I'm controlling. happy to stop that credit card charge as soon as you bring the lenses back. And so just like they can go and call and cancel a credit card for their gym, that doesn't let them off the hook for the subscription or the membership that they paid. That gym then has the ability to sue them. I don't think I'm going to sue any of my patients, but I do have a document that says this is our agreement. You bring those lenses back and I will stop the service. So, I'm not going to sue anybody. But that's kind of the way I set up the agreement. And yeah, 1 or 2 or 3% of people are going to take advantage of me. And that's okay.
And the reality is with how you have things set up, my understanding of it is that you are collecting a larger down payment up front that probably covers a lot of your material costs and things like that, correct?
Thank you, Christie. The first year of a subscription, I charge a high dollar amount for the fitting. And if the patient continues to do the subscription, then the fitting plus the monthly charge goes into place. If they stop the subscription, they have to pay the fitting fee again. And so if they're like, oh, we just want to go out of this for 6 months and then we're going to come back, it probably would be cheaper for them to just stay in the subscription model.
Right. And but it also minimizes your risk of loss too, because you've collected
2 months. Yep.
Yeah.
Yep. We would still be ahead.
Yeah. So the risk factors there are really low. I honestly, I think it's absolutely genius. When you told me that, I was like mind blown. I don't know. There's so many upsides to that, like with even just, thinking about your profit and loss statement at the end of the month and just like the consistency there and the ease of ability to sell that to a patient, when it's a consistent fee versus like these really super high upfront costs. Like this is, it's a brilliant system that you have set up. So one of the doctors would like to know if you have some advice with marketing and advertising your myopia management program.
I absolutely do. And I'd be happy for you to email me because that may go beyond the scope of this. So
we could probably do a whole webinar just on marketing.
And I don't think that people market specialty lenses very well. I've given several marketing presentations at the Global Specialty Lens Symposium. But really, this is your opportunity to go out and tell people this is what we do. And it's more important than, hey, we're a great place for you to get your eyes examined, because then you're trying to differentiate yourself from everybody else. When you're talking about myopia management, you're trying to make a dent in the universe for these children. And it's really a public health concern that you need to do well. And so we do marketing on all different sides, and I spend a considerable amount of money. Most people in the marketing world spend 1 to 2% of their gross or their percentage of their operating expenses towards marketing. And for me, I think it's more like 5, 6, or 7%. And we're doubling down on it every year and going more because I want more myopia patients, particularly. We're actually targeting certain areas like these 2 buildings are good for me. And so I geofence around them and I say, hey, I want everybody in that space to see an advertisement from my practice 4 or 5 times. And then I actually track them with my marketing, how often those people from those buildings come into my practice. In December, we had 45 people who saw an advertisement that came into my practice. Now, not all of them were for myopia management or what they saw on the promotion. And then our website is a really, really important component, not because of what's on it, but because of the traffic that it drives to it. So last year, we had 40,000 visits to our website, and it resulted in 5,000 conversions of people either coming in or making a phone call. So those are important things for us to know because they're the way that people find you, particularly in a world where word of mouth is only minimally valuable to you. Your social media has to be at top notch, and you have to be sharing with people what's happening in the world of myopia and telling them about a condition that they don't think is a problem, right? And that's a big conversation.
Yeah. Well, and I think initially, even though myopia management is becoming more mainstream, we're talking about it more. it's still relatively unknown for most parents. So when you're introducing those concepts, it's new to them for the most part. So 100% agree. It's a steep learning curve. In regards to subscription models, can your patients use HSA funds on that? I know HSAs have certain criteria that funds can only be used for services rendered at the time of service. From what I've learned with orthodontia, it's only the service that can be used to pay monthly on HSA. Do you know if that's something different?
Yeah, I can't speak with authority on all of the HSAs, but we certainly would work with our patient if they did have an HSA to make it work for them, right? I mean, they want to spend the money. And so, how do I get their money? Like, here's somebody who wants money, and here's somebody who has it. And I will guarantee you, I will find a way to take their money. Um, and one of the ways that we can do that is we do have an option that is a private pay or an insurance pay myopia management charge, which actually is higher than the subscription because we get our money right away through the subscription model. And so there is an additional fee that people can pay if they want to do kind of a global. It ends up being more expensive though.
Okay. And then what are your best tips for getting parents to commit to starting orthokeratology? I don't know if I'm not presenting it well, I'm not scary enough or what, but I've been offering ortho-K for many years and I have less than 10 patients doing it.
Well, good on you for continuing to push for it. I'm going to tell you something that may be a little bit offensive, and that's easy because I can't see your face. is I don't think you're a big enough believer. And I did ortho-K and I did myopia management for years. But when I became a believer at a point where I hate myopia and I know what it's going to do, I couldn't let my patients go. And so even if they couldn't pay for it, I'd make sure that they were in some sort of a program. And so if the obstacle for them doing orthokeratology is the complexity or is the cost, find out what's the obstacle for your patients not moving forward with it, and then move forward. For me, from a communication standpoint, I just share with them, hey, I wear these lenses, and so does my daughter. I have a daughter who's doing orthokeratology, as I mentioned. And I've got hundreds of children that are doing it in our office. And you can say that there are, thousands of kids all over the country that are doing this if you only have 10. And then share with them that, hey, this is a great option for kids for contact lenses because they can wear the lenses at night and they don't have to deal with their vision correction at school at all, right? One of my daughters has an ad and she's in VT and so forth, and she wears glasses, right? I mean, we deal with glasses problems all the time. And this way we don't have to deal with any of those things. And that's a big advantage for parents. And so that's a big one. And then the other thing that I think is really helpful for you is to just say that maybe you're doing a study on 5 patients. In your practice, you're just trying to figure out what needs to be done. And from a low cost perspective, just try like on 5 people. We're doing a study right now to see how well this new lens works in our practice or whatever it is. And it just gets you in the swing of doing it. And it's your education, right? You pay for education when you went to optometry school or whatever school you went to. So this is an educational cost to you. And that'll gain you the confidence and you'll do more and more of it. And then set targets and goals for yourself, right? I met with my team today and I told them that we're nearly doubling our myopia management patients next year. Like we're going big. And I told them how much we grew over last year. And they were like, are you kidding? Like we're like, and I'm like, yep. And we're marketing the heck out of it. Set targets for yourself. Like I have to do this many by this period of time. Now, if you truly have no children come in, then that's not going to happen. But I'm going to be doing this many each month, 2 or 3 or 4 of them, and I'm going to have to find a way to make it work. And then set targets and goals and make it accomplished.
Yeah. So you actually really bring up a really great point. I actually have a SMART goal worksheet that I use with new accounts when we're kind of onboarding and really trying to figure out like what their goals are. And I'm happy to share this with everybody. We'll go ahead and we'll send that out. And it's a nice way to, kind of get to thinking about like what you want to get out of your own myopia management plan. Trying to put some goals down on paper, figure out, just thought process wise, like what are your roadblocks, like what are the things that you're going to need as far as tools. And then if you have any questions, once you kind of get that filled out, feel free to reach out to me. I've got my Calendly in the chat here. Feel free to schedule an appointment with me if you guys want to touch base and ask more questions about some of that. But one of the other things too that I think we're going to cover in more detail in the third webinar series is really that parent communication. And I'm a really big advocate of making certain that we're doing an introduction of the concepts of myopia management at the end of an exam, but then we're also doing an actual consultation that's dedicated. And I think that I know for a fact it made a huge difference in our practice, where when we were trying to do it at the end of an exam, the acceptance rate was really low. It was like 49%. And I know our upper management was like high-fiving because they were like, yeah, these are really great numbers, because, even if you do a couple myopia management cases a month, you've increased your bottom line by several thousands of dollars, in a month. But I'm sitting here thinking, well, 50% of the kids I talk to are going to get worse. This isn't high five material. How can we do better? And so, one of the things that, I was talking with some of my colleagues, and, he's like, the parents aren't mentally prepared to hear about a solution to a problem they didn't know that their child had. They need some time and some resources to really think about, like what you just told them, and bringing them back in for that consultation really helps, solidify, we've identified a problem. Here's how we're going to address it in a subsequent visit. So really separating that out versus trying to rush and do it at the end of an exam. All right. And then we have just a couple more. Somebody would like to know, how do we email Dr. Kading for his marketing tips?
I'll go ahead and put those in the chat.
All right. And then we have just a couple more. Somebody would like to know if you could describe how you bonus your staff on myopia management.
Yeah. So I don't actually bonus them specifically on myopia management, and nor do I bonus my staff on spectacle and sales or those sort of things. And there are bonus strategies and tips that we could, again, go into a whole nother webinar on. But 4 or 5 years ago, I learned about a gentleman in optometry whose name is Danny Clark, and Danny brought in a corporate structure into his practice that's called the Great Game of Business. And what it is in brief, it is a profit and loss statement that my staff runs. They get together at a staff meeting once a week, and they run numbers for every area of our practice, from optical to frames to myopia to lens sales, spectacle sales, specialty contact lens, regular contact lens, yada, yada, yada. And then they project how they're going to do each month. And then we give them the numbers at the end of the month to show them how they actually did. And they do that every year, and they do it every week. And they also look at the expenses, and they look at staff costs, and they look at everything. We show them everything. We don't tell them how much anybody is making, but we share it with them, and then they get to see what the profit is afterwards. And I shared with them today that profit does not go into my pocket. It goes into equipment, it goes into all this stuff. And I share a percentage of that profit with them, and they get to see how they can impact the numbers. So they can see that, hey, we didn't do very well last month in contact lenses or spectacles. So look at our, revenue that's coming in, but oh my goodness, our expenses were still the same, and they were high, right? We still had people working. And so they get to see that every single week and every single month. And then we bonus them on a quarterly basis based upon the success of how well they did. I didn't come up with this. It was something that Danny Clark really implemented it. And he does some consulting I would say it's the number one thing that I've done for my practice to get everybody on board, and that has successfully moved it to a place where we have been double-digit growth. Last year we grew 20%, double-digit growth for 5 years straight since we started it, and it has really brought the team together as well. And sometimes you get together at a staff meeting, you're like, what do we do, right? Well, if we're not doing well in contact lenses, then we can set up a contact lens training, right? Have a rep come in. If we're not doing well in a certain, then we know where we're not doing well, and everybody can be like, hey, we got to do better at, and then they can all get together. So that's how we bonus people in my practice.
And then the last one, I think, is for me, and it's when doing the first few fits. Does Euclid have reps that come out if you need help with fitting? If I'm able to get 3 to 4 patients and maybe scheduled in the afternoon. We are a small staff, but I think if we plan this ahead of time, we could absolutely work something out. So Joel, if you want to go ahead and reach out, you can send me an email or set up an appointment on my Calendly, and we can discuss the logistics of that. All right. Can you believe we went a half hour over?
I enjoyed it. It was fun talking.
This was really fun. So for everybody who's still on, thank you so much for joining us. This was really great. Just a reminder, if you do join in on the other 2 webinars, we do have some amazing promos for lenses. It's 50% off the next, I think, 3 fits. And then if you're new to Euclid, you also get your first pair free, and it's warranted. So again, please reach out if you have any questions, and thanks so much for joining us. Have a good night.
Thanks, everyone.